Welcome to the 2022 webinar series sponsored by the Association of Neurovascular Clinicians. Hello, my name is Marcy Beeson, and I will be moderating this session, Onboarding New APPs. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-empowered clinicians that fully support the holistic needs of the patients and their families, because stroke patients deserve nothing less. This series has also been endorsed by the Society of Vascular and Interventional Neurology and Mechanical Thrombectomy 2020. For more information about the ANVC, please go to www.anvc.org and become a member. So we do have a few housekeeping items before we begin. This session will be recorded and available on the members only section on the ANVC website at www.anvc.org. You will receive one continuing education hour for the live session only, so you must attend the entire session to receive credit. After the session is over, you'll receive an evaluation from the Arizona State University. After you complete your evaluation and return it, you will receive your continuing education certificate. Please feel free to enter any questions into the chat throughout the presentation. We will have time at the end of the presentation to address questions. So today I'm proud to introduce our presenter for this webinar, Julie Shaver, Physician Assistants. Julie is currently a physician assistant. She went to PA school at the University of Mount Union. She's currently working with ProMedica Neurology since 2014, with ProMedica Toledo Hospital Comprehensive Stroke Center since 2015. She's the leading advanced practice provider. She's a regional stroke coordinator, stroke quality data abstractor, and analyst. Julie, take it over.
Thanks, Marcy, for the introduction. And thank you, first of all, to the ANVC for inviting me to give this lecture. This is something that I'm very passionate about. And I'm very honored and excited to be here to present this. I truly am very passionate about stroke. I'm also very passionate about advanced practice providers and us working at the full extent of our license, the full scope of our practice. And I think that the onboarding process and really empowering advanced practice providers is one of the most important parts of creating a really good environment to care for stroke patients. So without further ado, I have no financial disclosures. There's a quick outline. So why is this such an important topic? Well, in general, there is a huge shortage of physicians, and specifically there is a shortage of neurologists across the world, especially across our country. A recent report suggested that 40 states currently have a shortage of neurologists. I believe it's probably more than that. In 2025, we're expected to have a shortage of neurologists by about 19%. In 2033, in general, the United States is reported or expected to have a shortage of physicians by about 140,000. And this is where I think we can pick up a lot of the slack here. It is such an issue with our aging population who, as you age, you have an increased risk of developing neurologic disorders, Parkinson's, dementia. And so the American Academy of Neurology's Transforming Leaders program recognized that this is a huge issue, to the point that they wrote this report and published it in the Journal of Neurology, where they are putting out ideas for how to encourage residents to go into the field of neurology and how to get more neurologists out there. But what they kind of left out of this report was that some of the gap can be filled by advanced practice providers. Now they did release a position, and they update this frequently. This is the AAN. Saying that they believe that the integration of APPs into the field of neurology to form care teams is crucial to improving access, quality, and continuity of care for people with neurologic disease. We know that, but they also state it's necessary to recognize that there is a scope of practice to allow the care team to practice to the full extent of their professional license, their training and their abilities. But the AAN, they hold a strong position that promotes physician-led multidisciplinary care teams. Although, they are supportive of expanding collaborative role with APPs in neurologic care. So, this shortage of neurologists, the shortage of physicians, the AAN releases a statement that they're supportive of advanced practice providers, but we have to recognize our scope and things like that. Fully on board with that. I completely agree with that. But it's important then to train your APPs to practice to that full extent of their license. I've seen so many APPs who are just scribes, and that's not how we should be onboarded. That's not how we should be trained, and that's not how we should be utilized. So next, let's look at some trends for APPs. There's approximately 270,000 nurse practitioners, about 131,000 physician assistants. The number of APPs per 100 physicians has increased from 2001 to 2016 from 15 to about 28. So it's almost doubled. And, I think that number, we know that number is skyrocketing. So by 2030, it's estimated that there will be about 54 APPs per 100 physicians. So that number is expected to almost double again over the next 14 years. According to the Bureau of Labor Statistics, the growth projections for advanced practice providers are much faster than the average for most other professions. So the projected growth for APRNs over a 10-year period from 2019 to 2029 is 45%. Over that same time period, physician assistant jobs are projected to grow by about 31%. So we're out there. And why use us? Well, there are a lot of advantages that have been proven in multiple studies and multiple reports. We know that advanced practice providers improve quality of care, improve access to care, we're cost effective. Compared to vascular neurologists, the supply of advanced practice providers is abundant, and we're growing at much more rapid of a rate than vascular neurologists. We complement vascular neurology expertise. I would argue that we bring a lot to the practice. We bring a lot to the field. We bring new ideas and a different way of looking at a patient, perhaps. We improve capacity on an inpatient service. So you can have one physician rounding on 30 patients, 30 stroke patients with an army of APPs. Or you can have one physician trying to round on 30 stroke patients, and that provider is going to be pulled at the seams. There's no way that they can really give high quality care and really investigate all the nuances of every single patient without help on 30 patients. The Society of Critical Care Medicine released a report where a team did a very concise review of literature over a 10-year period. They looked at studies addressing APP utilization in critical care. Pretty much they did a very extensive review of multiple studies. There were hundreds of them, and they put everything together, and collectively, these studies identified the value of APPs in patient care. They reported, better continuity of care, improved quality of care, improved safety metrics, increased patient and staff satisfaction. And then another thing I thought was interesting was adding APPs to the mix also enhanced the educational experience of the residents and fellows for a few reasons. One, the APP themselves is someone that the neurologists and fellows can look at and learn from. But additionally, we take a lot of the burden off of the vascular neurologist, the physician that's rounding. So they have more time also to spend one-on-one teaching these residents and teaching these fellows because we take up a lot of that work. So, there are so many advantages to having advanced practice providers in your practice. So what's the problem? It sounds like it's super easy. There are a lot of APPs. There's a physician shortage. Just hire the APPs. put them in the hospital, have them shadow you, they'll figure it out, right? Well, we know that, not everyone is created equally. Not all APPs are created equally. So finding the right candidate is really difficult. And I think that that is one of the most important parts of onboarding, is that you have to have a good candidate. You have to have someone with drive, with passion. They might not know anything about stroke, but if they have the desire to learn, and they have that passion that can be fostered, then you're on the right track with something. But if someone just views this as a job, this is not the right field for them. I know there's probably everyone out there has been somewhere where someone asks, what do you do for a living? And I'll say, I'm a physician assistant. And I'll say, well, oh, what do you work in? What's your specialty? And I'll say stroke. And they go, oh, I'm so sorry to hear that. That has to be so hard. It just makes me laugh. Yeah, can it be hard? Of course, but I love the disease process. And trying to explain that to someone is difficult. They just think that we zip up patients in body bags and send them to facilities all day. And I hope that's not what's happening for most of you guys out there, but helping someone get better, or helping someone cope with their disability, or learn that this is, this might be their new normal, or providing them hope that they're going to get better. That's one of the greatest parts of the job. And, or helping families, find comfort and peace in difficult times. But also, it's the pathophysiology, it's the complexity of it, it's that puzzle. You have to find the right person for that. This is not, like I said, it's not something that is just a job. There's so much that can be brought to this field, that if you're just finding someone who's coming in, punching the clock, writing some notes and going home, you're really missing out. So that's one of the most important parts that we'll talk about a little further. The other biggest problem is establishing an onboarding process that actually really fosters that growth and facilitates the excitement around stroke, and involvement in the program in general. It's difficult. There are programs out there that we're going to talk about, but creating your own really takes a lot of work. It takes a lot of effort. It takes a lot of time. So next, let's talk about just APP programs in general. And again, why this is difficult, the onboarding process and finding candidates and things like that is a little difficult. So NP programs, they vary in length from 1 year intensive didactic and clinical programs to up to 3 years, which may or may not include a doctorate. The graduates obviously have to pass a national certifying exam and obtain additional licensure. The adult gerontology, acute care nurse practitioners, they are intended to work primarily in the hospital setting, from emergency acute care, step down general care. Coursework also contains content on post-acute stroke prevention. So, their clinicals can be tailored more to stroke education. PA programs, 25 to 27 months. They include 1 year of didactics and a minimum of about 2,000 hours of supervised clinicals. Most of those clinicals are centered around primary care, pediatrics, surgery. There are electives. But unless you find someone that really knows that they wanted to go into neurology and did a neurology or a stroke elective, outside of seeing those patients, maybe in an emergency room setting during their clinicals, or maybe at a primary care physician's office, they might not have a lot of in-hospital experience caring for stroke patients. PAs also have to pass a certifying exam. They also have to complete state licensure. But again, it's a broad training. There is a certificate of additional qualifications, a CAQ program that physician assistants can obtain, which essentially requires 4,000 hours in a subspecialty practice, and you have to pass a specialty exam. It's not available for neurology. So it's available for, I think there's maybe 5 or 6 different specialties, including like cardiothoracic surgery, I think emergency medicine, but unfortunately, neurology is not one. And before, stroke would have to come neurology. So this is still a long way off for physician assistants. So in general, that kind of takes us back to a lot of advanced practice providers might not have a lot of training in stroke when they graduate and when they're, being released out into the world to work. So how do we develop this onboarding process to really foster a good APP and develop a good APP? Step one is choosing the right candidate. We at our institution, I just don't think that you can really get to know someone. I think it's hard, actually, I should rephrase. I think it's really difficult to get to know someone in an interview setting, especially a lot of interviews are, webcam now. I think it's really difficult. It's something that I struggle with, and maybe that's just me personally. But they're on the top of their game and they've practiced what to say and things like that. It's hard to really gauge someone's interest in their personality unless they're really passionate about it. There's those people that are really passionate about it. You can sense that from them in their interview, but a lot of people are, you don't really know. So we request that unless we really feel it from their interview, everyone shadow us. So after our interview process, we bring them into the hospital as an observer, give them an observer badge. They fill out some paperwork and things like that. And we purposefully bring them on a busy day. So our Wednesdays are our busy days. We round in the morning and then we go to clinic, and it's a crazy clinic. So we purposefully bring them in. We expose them to everything we can. The sick patients in the ICU, the stroke alerts, the step down patients, the trached and vented patients who are waiting LTAC placement. And then, we come and we eat real fast while we're doing our notes, and we go over to clinic. We purposefully show them a very busy day. We want them to see that it can be stressful. We want them to see that patients are sick. We want them to see that we're making complex decisions, but we also want them to see how rewarding it can be in a clinic when you see people walk into your clinic that you weren't expecting. So during that time period, we're assessing, are you asking questions? Are you interested? Are you a deer in headlights the whole entire time? Because you're like, what am I getting myself into? So I think that has helped us kind of weed out some people that interviewed well and then came in there and were like, oh my God, I want to go home. I want to go take a nap. But it's also showed us some people who didn't interview well, but came into it and were like, man, I love this. This is awesome. So I think that has really helped us. And that's a tip that if you are able to do that, I would highly recommend that. Really spend some time with your candidates. We're looking for characteristics. We're looking for compassion. We're looking for positivity, prioritization, the ability to know which patient is most important. And, if you're down in the ER and you're getting 2 stroke alerts at once, which one do I go to? The ability to critically think fast and to prioritize these patients, the ability to deal with stress. And that's why we bring them in on a busy day, so that they can see this isn't always easy. And strong communication skills. I want to get that from them, that they're not going to freeze, they're not going to forget things, and they're going to put things, in an important order that we can, really get to the point quickly and make some complex decisions fast. So after picking the right candidate, it's the onboarding process, which is, the meat and potatoes of creating, for lack of better words, a great PA. There are established programs that you can go with. ANVC has the ANVP board exam. There are some residencies or fellowships, and then there's the NetSmart advanced practice. So I'm going to start with the ANVP board exam. So this is a board exam by ANVC, which I'm sure most of you probably know about, or a lot of you know about. Really vets APP readiness for independent or semi-independent practice. Fosters them to be able to work in expanded roles, including telemedicine, mobile stroke unit, emergency department responder roles, where the physician is not directly overseeing you. The board certification helps to demonstrate APP expertise in the assessment, the medical diagnosis, looking at localization, neuroimaging interpretation, and also assesses the readiness for hyperacute treatment decision-making for stroke patients. The blueprint is over on the side, so it goes through everything from stroke pathogenesis, hemodynamics, risk factors, epidemiology, some research, primary, secondary prevention, additional information on imaging or interpretation, localization, reperfusion, hemorrhagic stroke, severe stroke management complications, and then some things about stroke center leadership. And I just printed this out in case people aren't aware, but the cost for the board exam, $350 for ANVC members, $450 for non-members. And if you want to do the review course, it's $200 extra for the review course, or $300 for non-members. So, this is your board exam for a stroke APP. And I think if you're training an APP in practice and you feel like they're ready, you can really assess their readiness by having them take a board exam. For a little more about the program, you must complete a postmaster's degree fellowship program. But right now, until December 2023, you can kind of grandfather in the program if you have your master's degree from your advanced practice provider program. And you've worked as an APP in stroke for 5 years, which has been validated by a hospital administrator. And you've completed at least 1,000 hours of clinical hours of APP education in it. So this is one of the programs that's already established for you. So you don't have to start you don't have to start from scratch. If you don't want to start from scratch, there are things out there. Additional programs out there, residencies and fellowships. These terms are used interchangeably. However, fellowship is preferred for advanced practice providers. I went online and I was trying to find specific stroke fellowships at hospitals across the country, and it seems like most are neurology or neurocritical care. So a little more broad, which isn't a bad thing, but when you're really trying to train your stroke APP, I think it's helpful to start out a little more basic and then maybe expand the knowledge from there. Currently, there's approximately 15 residencies or fellowships in the United States. All but one require relocation to the site of the program for at least a year. And most, like I just said, most are not stroke specific. There is one fellowship program that is distance accessible and focused exclusively on acute stroke management, which is NetSmart, the Neurovascular Education and Training in Stroke Management and Acute Reperfusion Therapies for Advanced Practice Providers, which is the next thing that we will talk about. So these are all your modules for NetSmart. I'm not going to read through all of them, but pretty much has the same framework as the ANVP exam, except really kind of gets into imaging, angiography, but a very thorough system, a very thorough program that's been set up. And you essentially complete these modules, and then you have post tests on these modules. So each module goes through clinical skills that embed, your knowledge and practice. You have to pass the post test with at least a 90%. On average, it takes about 14 months to complete. And afterwards, you can sit for the ANVP boards, and there is 100% pass rate, which is pretty good. A little more about NetSmart. It's funded by the United States Health Resource Services Administration. And the whole purpose of it is to improve acute stroke treatment outcomes by increasing the number of APPs that are working in acute stroke. So I'm going to keep going here. The next is create your own. And I put a little like Pinterest veil on here, not to discourage people from creating their own programs, but just to put it out there, it's really difficult. This is what we've done. We've done a create your own, and I think that it's working. I think that it's helpful, but it took a lot of work and it took a lot of time. So when I joined our program, we were a primary stroke center, we were doing intervention, and we were seeking comprehensive stroke certification. So, the onboarding process for APPs wasn't on the top of anyone's list. In addition, I was the second APP. So it was just me and another girl. We worked a lot of hours. We worked a lot of hours. Anyways, we have now grown. We're at 6 now and trying to hire 2 more, plus we have residents and fellows. So it has just, boomed, but that growth has, really opened our eyes to, we need a formal process for this. I was trained essentially like a fellow. My attendings at that time had a vascular fellow. And so what they put her through, they put us through, me and the other advanced practice provider. And then as we were bringing more APPs on, we really sat down and had to kind of develop a blueprint or an idea of, how can we be thorough, give them enough time and give them enough support, but make sure, that they're practicing safely and we're not just throwing them out there. It's not impossible, but it just takes a lot of time. It takes a lot of one-on-one time. I think you need to be prepared to amend your curriculum to the expertise of your new hire. If you're hiring someone completely out of PA school versus NP school, it's different, versus hiring someone who's been a hospitalist for 3 years. And it does require a lot of one-on-one training from an APP standpoint. I think that one of the most important things you can do in your onboarding process, though, is to incentivize the APP. There are APPs want to learn, but they really want to learn when they're incentivized with something. So maybe it's monetary incentivizing them with raises or bonuses or whatever it may be, or maybe it's, when you complete this, then you can go ahead and start seeing these patients, or when you do this, you can start seeing these patients. So create some milestones, and that really puts it in black and white for your advanced practice provider. So maybe once they are able to assess patients in the emergency department, or once they can really manage the step-down patients, they can be given 1 or 2 ICU patients. You should assign some learning, assign some modules as the APP is moving on, do some little tests for them, so you can really assess how much they are retaining and how much things are clicking to them. So, obviously you have the NetSmart modules. That's a good way to assess them as they go along their process. You want to progress the assignments and the clinical experiences based on the knowledge and the skills that have been attained by the APP, which you're going to assess the APP as they're going, and then give them more things, and kind of increasing those privileges. So for us here, like, telemedicine is the last thing that we give people, because I think, unless you show me that you can really assess a patient in person and know how to manage complications in person, I think that's really difficult to do via telemedicine. But telemedicine is also something that can be done remotely. So it might be desirable for the APP to do telemedicine. So it's one of those stepwise approaches. As I mentioned earlier, if you are able to, with your institution, consider some financial incentives, adjusting salaries or giving bonuses, or maybe the bonus is that your research department or someone will cover the cost of the advanced practice provider to go to a national conference. education and training costs should be covered by the institution. One of the suggestions that we had, this is from another presentation, was that the board exam and the review course for ANVP should be covered by the APP, but if they pass, then it should be reimbursed, which makes a lot of sense. I think that conferences are something that's desirable and that are fun to go to. So that's another thing that's not only a financial incentive, but also will help the APP learn and grow and network. So that's something that we kind of try to do is, getting through your year and then going to ISC, and meeting some people and networking, or going to SVIN or an ANVC conference. So something that if your institution will allow, or maybe your research department, or maybe even your docs, getting a lot of those costs reimbursed and paid for will be helpful. So this is a lot. But I put what we do of our kind of onboarding process, and it's a 6-month process, and it's very, very fluid based on the APP. But I'm just going to highlight a couple things that we do. You can read this if you want. This will be available to you. But there's a couple things that we have done that have really helped. One, the process for credentialing is a nightmare. It takes forever, and I don't want to hire someone and have them sitting at home for 6 weeks waiting to get in the hospital, start working, or to start learning. So we have convinced our institution to start the APP the first of the month after they sign their contract. And we bring them in to shadow us. So they sign their contract on the 15th, the following month on the 1st, they are part of our team. And they are following us around in the hospital as an observer. And during that month, they are completing all, the orientation process. They're getting their badge and security, or doing all their health streams modules, or whatever stuff is needed. Oops, sorry, that was just my pager. It's not a big deal. They're getting all of their things that they need to from an institutional standpoint, but there's a lot of extra time that they're following us around in the hospital. And this has helped just, one, it's not much pressure on them to just be observing for a month. They're seeing how we're interacting with patients and families, seeing how we interact with each other as APPs, how we interact with our research team, and how we interact with each doctor. They're kind of learning already some of the nuances of the doctors, which doctor likes to know what and how in depth they like to go. I think it helps them hear the language that we use when we're speaking to patients and to families. I think that's one of the most difficult things to teach an APP is what to say and how to say it. So they follow us for essentially a month. And during that month, they're also doing their NIH, they're doing their modified Rankin training, they're doing their city training to be able to be on our research trials, and they're doing a lot of the basics. So we have made some books. We have Basics of Stroke, which is vascular anatomy, stroke risk factors, primary, secondary prevention, and then another PowerPoint that I created that's basically helping with localization. So your left MCA inferior division stroke, what that looks like versus a superior division stroke versus an M1 occlusion versus your basal ganglia syndromes, your posterior circulation syndrome. So helping them with, they just did their NIH training. They're watching us do NIHs. They're seeing stroke alerts and then being able to read a localization book for how things, looking at symptoms and placing them in the brain. And then as things progress, we give them more. So more neuroimaging, taking 1 to 2 patients, always supervised by an APP until, 4 to 5 months. Usually starting with simple step down TIA patients and then working themselves up to the ICU patients. And then eventually getting into telemedicine, getting into outpatient. I also do a lot with neuroimaging with them. So, the basics of neuroimaging is something that we go through in month 1, but then kind of starting in month 2, we'll open up a CTA and they run it. But randomly, I'll just make them stop and I'll say, all right, show me, maybe it's right after the arch, and show me your left subclavian, show me your left common, show me the brachiocephalic, show me, where the right common comes off, show me this, show me that, show me, sound very needy. But that way I know that when they're scrolling through and they're controlling it, they know where they are at all times. So you could stop them wherever and say, all right, what are you seeing? Where's this? Where's this? Where's this? Where's this? And they can point to it. And that helps me know that they know where they are. And then the next thing I do is I give them a Excel spreadsheet that has 10 medical record numbers and 1 sentence, right hemiparesis and aphasia, or left hemiparesis or unresponsiveness. So they kind of know where to look. And I have them go through the CTA independently. I'm not even there. And they write down where they think the occlusion is. If there's an occlusion, there's also 2 that are completely normal. So I want an APP to be confident looking at a CTA and saying, this is completely normal, there's no occlusion. Or an APP to be confident to say there's a left M1 occlusion. So they write it down, then we go over it together. There's some tandems in there, there's some baselars in there, there's some M2s in there. And then, we go through it together. And depending on how they did with that, I might give them some more names, or we might move on to the next step, which is 10 names, no symptoms. And I feel that if an advanced practice provider can pull up a CTA, know absolutely nothing about a patient, and look at it and find something that's wrong, or feel confident enough saying this is completely clean, I feel that they're ready. They're ready to go to ER, and they're ready to look at neuroimaging to help make acute decisions on at least endovascular treatment. And that the CTAs usually come after looking at regular non-contrast CTs and MRIs. Those are just a couple things that we've incorporated into our program, but this took a lot of work, and there's no certificate at the end of it or anything. It's just a slap on the butt and tell them to go see some patients now, go assess some patients, go do some stroke alerts, and that way I can go back to the office and sip some cocktails, I wish. So the bottom line, APPs should not be viewed as PGY2 residents that are only assigned to do things that the attending physicians don't want to do. I'm going to keep kind of clicking through here. I don't remember how many I put here. So, okay. All right. We are not scribes. We should not be viewed as scribes. We should not be used as scribes. I'm sorry, whenever I'm training an APP, I always tell them, when you're presenting a patient, you present the subjective and present the objective data, but then present your interpretation of the imaging. So, CT read this, but when I looked at it, I actually think that maybe there's X, Y, or Z. And also present your assessment of the patient, what you think the etiology of the stroke is, and your plan, how you want to fix it. Present all of those things. And maybe you're wrong, I'm still wrong, but at least, you put things out there. The physician knows how you're thinking, what direction you're thinking. They foster trust in you. They develop that sense that you can be independent, that you can make decisions on your own, but also you might just bring to light something that the physician hadn't thought of. We spend so much more time with these patients than our docs do. I know, what Sally ate for breakfast yesterday, just because we were joking about it, whereas my doc might not care about that. And I might not either, but it's just part of the conversation that we have with them. So I think, but sometimes, when you really get to know these patients, you bring out information that they otherwise might not have told you. So, developing that trust with us, maybe a patient is more likely to tell you that her brain bleed, or she had a severe headache that was actually postcoital, and they wouldn't have told you that if they weren't comfortable with you, or if they didn't, the doc walks in the room for 2 seconds, they might not feel comfortable telling someone that. Well, that's a huge piece of information. So I think, we can really add to the patient care. We can really add to the story. We can add to the assessment, the workup. And I hate when I see APPs in the back and they're just, they're reading the subjective, and then they're telling the docs the labs and the imaging, and then that's it, and then they're just like, okay, let me put in the orders, I'll do your note for you, and then I'm going to go home. But that's not what we're meant to do. I think we can bring a lot to a program. We have a lot of ideas, and I think we can look at things a different way. When you're having high turnover in your institution, you need to take a step back and look at things. So is it a poor work culture? Are APPs not allowed to grow? Are we not allowed to improve? Are we not allowed to really participate in the care of patients? Or, are you hiring the wrong APPs, and how do you fix that? How do you, what are some things that you can do to try to make sure you're really getting the right candidate? I think, when you're investing in advanced practice providers, it's going to lead to program loyalty, that high retention rate, high rates of employee satisfaction, consistency for how patients are managed, and that's going to translate to better outcomes in the long run. Instill confidence in your APP. That's something that you should continue to do as you're onboarding them, as you're giving them, more things to do. You're adding more to their plate. They should feel confident about that, and they should feel ready for it. Again, I guess I already talked about, how I have them present their patients. I make sure that they present everything. They should ask questions, always ask questions. I still ask so many questions just because we're never done learning. There's always things that are changing or growing. There's always things that I've never heard of that come up every once in a while. I think you should challenge your docs. If you think a patient should get TPA, but they tell you no, but you really feel in your head that in their heart that patient should get TPA, I think you should fight for it, and tell them why. And ultimately it's up to them, but maybe you will change their mind on something, or, I don't think that it should just be the bottom line. If you really feel some way about treating a patient, I think you need to have a conversation. You have to foster a conversation. You should feel comfortable doing that with your docs. And then I think also encouraging your advanced practice providers to participate in building and growing your program beyond just rounding in the hospital. So doing more things. So I do some quality data abstraction and analysis. And every month we have a team meeting. And if I notice our data is going one way or another way, I'm going to bring that up in our team meeting, and we're going to sit down and we're going to figure out why. Why are our TPA times bad this month? What happened? Were we short? Whoever was mixing TPA, or was there issues with that? Were we short-staffed? So that we can figure out what happened and how are we going to fix it. So that's something that I'm very passionate about. But some of our other APPs are passionate about other things. So one of our APPs does an educational program with our nurses. She's a former neuro ICU nurse, and she feels very passionate about empowering our neuro ICU nurses up there, and continuing to educate them and foster, their love and their knowledge for treating our patients. So every month she does an educational session with them. She goes up there in a room and she just sits and goes through something. And maybe it's just blood pressure management post thrombectomy. Huge, very important, that maybe the nurses don't realize how important that is. And I think that's her passion. And so that's what, we fostered for it. She ran with it. So I think that's, incredibly important. It's not a job. It shouldn't be looked at as just a job. And I strongly encourage everyone to have your APPs give more to your program, because I think that we can change things. We can change our programs. We can make them better. And we can fill a big gap in healthcare right now. So thank you so much for your attention. I wanted to end a little early. There's some of my references. I wanted to end a little early because I think that this is a topic that perhaps some other individuals out there have ideas that have worked for them, or things that they've done with their onboarding process that have really helped. I'm hoping that maybe you guys got some ideas here that will help with the onboarding process of your APPs. But I'm going to stop here and just see, does anyone have any tips, tricks, things that they would recommend to really help with this onboarding process for at your institution? Okay, so everyone seems really, really excited about this. So nothing, no ideas, no little hacks that people have. That's okay if you don't. If you do, maybe you can just share them with the ANVC staff and they can attach it to this webinar. But let's see. Oh, okay, I'm reading the chats now, okay. Our SEO program recently hired 3 APPs.
Yeah, Julie, your chats are coming in now.
Oh, okay. I love your program and ideas. How do you pull in MD and admin support? Okay, so how I pulled in admin support was with my MD. And so our, I'm sorry, that's my pager that I dropped on the ground. All right, so our, we have a really good relationship with our administration. I think that that's very crucial. But I'm gonna go back to our process just so that you guys can see this too. With our MDs, while we were in the hiring phase, we went to our administration and we said, it doesn't, there's an onboarding process, I think, in general with APPs, and it does not make sense to waste a month. It doesn't. And if, our institution was nice enough to let us bring them in with their full pay that first month, but we were willing to say, can you just maybe half pay or give them something so they're not just sitting at home doing nothing for the first month that they're hired, or not technically starting. But so we went with our physicians and our administration was very supportive of it. And I think that it really helped with our advanced practice providers. Other ways to pull in MDs. So we do weekly neurovascular case conferences that our fellows do, and they want us APPs to also participate in them. So our MDs, while we're rounding, maybe we'll have a complex case and they'll want one of us to put that into a case conference. I know that this isn't something that might be generalizable to a lot of places, but our MDs also do teaching rounds. Actually, this is one of a very helpful thing, but before we round on patients, one of my docs likes to sit down in a room and he goes through all the images and we go through each patient, whereas some of my docs go through the patient as we're at the room and the images. But whenever we're looking at the images or the docs are looking at the images, we're saying what we think. And so we encourage our APPs to read the images, our new onboarding APPs to read the images to the doc and presenting their assessment and their plan to the doc. And so I think that helps with the physician, one, knowing, is this APP ready? But two, it helps with that APP feeling confident speaking to the doctor, number one, and feeling confident, reading images and looking at things like that. So that's one of the ways, a few ways that we kind of pull our docs in with some of the education, is just making sure that when we're presenting to the docs, we have the new onboarding APP do it essentially. No neuro APPs at your hospital might be something to look into. I have had my training APP follow me and continue to increase our participation in patient care. the early start is a game changer. We've also had success in giving the new APP a list of all the thrombectomies from the previous year, and they reviewed imaging over the few months of orientation, approximately 150 to 200 patients. Yeah, I mean, that's great. And that's what I feel like maybe take some of those and just don't tell them that it's a thrombectomy, or give them some completely normal and completely clean CTAs, and don't give them any symptoms, and give it to them and tell them, hey, look at this CTA and tell me what you think, or tell me what you see. Because that's when you can really gauge the confidence of an APP in looking at CTAs. 12-week orientation plan. Each week we cover a specific diagnosis, and we try to find those type of patients for them to see. That's a great idea. We review up-to-date trials. They shadow neuroendo and neurorad, teach rounds daily, which we've gotten approval from CME, complete ENLS, MRS, NIH during those first 12 weeks. Yeah, we did do ENLS for a while. I don't know why we stopped doing it, but the shadow neuro ICU, that's a good idea. Each week they take an additional patient, then they get checked off on consults and ER stroke alerts at the end. Have you met any APPs who are both clinical and stroke coordinators? I'm a regional stroke coordinator, but so I actually went to the stroke coordinator conference by Joint Commission in Chicago, probably like 3 years ago when I first took over the regional stroke coordinator position. And I was told there that I was the first physician assistant that they had met. I do believe, I know actually that there are nurse practitioners who are also stroke coordinators. And I think that that is a great role for an advanced practice provider. I actually encourage that if you're able to have that, because I think as an advanced practice provider, you know, I feel confident going down to our ER and looking at our ER doctor and saying, you messed up, you know, and not everyone has that confidence, but and really looking at cases and diving into where things went wrong. I love the APP in a stroke coordinator role, and there are nurses out there who are phenomenal and brilliant at it, so please do not think that I am by any means diminishing nurses in that. We have a fantastic nurse in our stroke coordinator role. I work with her in conjunction with her. Oh, there we go. I am an APP and stroke coordinator. Do have my ANVP. I actually have some APP stroke coordinator resources. This is separate, but I did present at SVIN on, and this was one of the things I presented on, was the possibility of using an APP as a stroke coordinator. So I'm going to go back up because I love this idea from Elizabeth Orr to each week covering a specific diagnosis and then trying to find patients for them to take care of. I think that's a great idea. So we kind of do, so I'm just going to kind of go through that. Like month 2, we start giving them 1 to 2 patients, and then it's usually step down patients that myself follows with them. I'm going and I'm seeing them, I'm looking the patient up. As they're able to write notes, I have them write notes, and then I just review them before they sign them. We do a lot of neuroimaging. We have a booklet that we have made of pivotal trials. You don't know where you are unless you know where you've been. So, you know, they need to know everything back to, you know, NINDS and things like that. So we have that booklet for them to look at. And I mean, they don't need to know the ins and outs of every single trial, but as long as they know where we came from, I think that's important. We just do kind of one-on-one lectures, which are usually just an hour long on, you know, outpatient stroke management. And we tend to do outpatient first, only because have our patients see some outpatient first, only because a lot of it is secondary prevention. And, you know, I think a lot of that is something that is pushed in PA and NP school. And then the stroke specific part of that, we talk about before they are seeing patients, but they're seeing clinic patients under supervision of a senior APP. And then we just have them kind of continue to just watch us at stroke alerts and telemedicine alerts. In month 3, they're seeing some more patients. They're seeing usually still step down patients. This is when I quiz them on neuroimaging. And then I might give them the first stroke alert during month 3. A lot of times inpatient stroke alert. I don't know about your institution, but at our institution, like 95% of inpatient stroke alerts aren't strokes. So I might give them one of these, or a stroke alert that's outside of the time window for any acute intervention. And I'll just supervise them during it and step in when I need to. So that's something that will increase in month 3. Then we do a complication education, and then month 4 is when they're pretty independent in clinic. And that's when we start giving them neuro ICU patients, but always under the supervision of a senior advanced practice provider. Usually they're independent at that time on step down or TIA patients. We have them shadow our telestroke APP so that they can see that process and see how you need to adjust and amend things. And then start having them run some stroke alerts in an intervention window with just the senior APP backing them. And then month 5 is just them taking more patients, but we still back them usually in month 5 unless they are very proficient. And then goal is that they're independent by month 6. And this is a long program, but if you think about it, month 1 at a lot of institutions, they probably wouldn't be in the hospital to begin with because they would be sitting at home waiting for credentialing. Well, we've took that step out of it. So really it's I guess a 4-month program. And sometimes we need to go a little longer on things, usually not. Usually, if anything, we're able to progress people a little faster just based on their comfort level. And then we'll probably get into, ANVP board exams and things like that. So, am I employed by the hospital? Is the clinic hospital based? So this is interesting. I'm not employed by the hospital. I'm employed by a physician group. So I work for ProMedica Toledo Hospital, and we have ProMedica Physician Group. So, I mean, under one big umbrella, but 2 separate entities essentially. So, and it is the physician group that has allowed our APPs to come in to work early. But I think if your docs, and your docs should be on board with this by all means, but I think if they're on board with it and they are willing to speak to someone in administration, then, it just makes sense. It just makes sense. It doesn't make sense to have them sitting at home for a month. Our clinic is not hospital based. Our clinic is separate. Is a stroke manager, a hospital employee, and an APP. Our stroke coordinator is a nurse, and she is a hospital employee. And she is not an APP. Yeah, number of APPs who work dual roles. Many different nuances in each hospital. I found 1 or 2 literature that supports APPs as stroke coordinators. I did too. It would be nice to have some conversations about the topic regarding what really works well when the stroke coordinator is an APP who can order things. I will post in the forums and would like to hear from you all. And I'll post what I have in that too. So I do a lot of, as part of the regional stroke coordinator job, I do a lot of regional feedback. So cases that are transferred to us from outside hospitals, I give feedback to that physician, and to that hospital. So they get a page that just maybe has some pictures or things like that, so that they can, we can close the loop, and 2, they can see what they did good and what they did well and what they can work on in terms of, you should have called us earlier and that would have decreased your door to needle time, or you should have requested emergent transport and that would have decreased your DIDO time, or whatever it may be. So that's one of the things that I think having an advanced practice provider and that coordinator role is just a little different and maybe more helpful. Yeah. Anything else? I think the conversation here is great. I'm an RN working on my master's as a stroke coordinator, but have APP that responds to all code strokes in ER and inpatient. That's great. anything else that anyone wants to add or talk about, or I'm always happy to talk offline about anything or about our process, or to share any sort of anything that we have with you guys. So thank you all so much for listening. Thank you for the conversation after. I think there are some great ideas on here. And I am very proud to present this lecture and to learn from all of you as well. So thank you.
Thank you, Julie. Our next webinar is March 24th, 2 p.m. Eastern Standard Time, and it's the heart and brain working together for AFib detection in stroke patients.